Welcome everyone to this patient-focused webinar. I'm Shalene McHale from Insight Tech, and I'm pleased to be a part of today's virtual education event. Please be patient as we take just a few moments to allow everyone to get signed on. The presentation will begin shortly. Again, for those of you that are just joining, I see there's still people entering. We're going to allow just a few more moments so that everybody can get signed on before we do the introduction and begin the presentation. Okay, it looks like we have a great number of attendees signed on, so let's go ahead and get started. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Drew Kern of the University of Colorado as he discusses focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentation, please do not hesitate and go ahead and put your questions in at the bottom of the screen. You'll see the Q&A button right there for you to use. We will have time after the presentation to answer the questions that are asked within the chat. Now, let me begin by introducing you to our guest presenter, Dr. Drew Kern. Dr. Kern is a board-certified neurologist and movement disorders specialist. He is the associate professor at the University of Colorado School of Medicine, Departments of Neurology and Neurosurgery. He completed his neurology residency at the University of Colorado and completed his clinical fellowship in movement disorders under the mentorship of Dr. Anthony Lang. Dr. Kern completed his training in deep brain stimulation and advanced treatments in the movement disorders under the supervision of Dr. Alfonso Visano at the University of Toronto, Toronto Western Hospital. His research is focused on advanced treatment options for movement disorders. He is the co-director of advanced therapies in movement disorders and deep brain stimulation programs at the University of Colorado. We are super happy to have him with us this evening. Welcome, Dr. Kern, and thank you for presenting this afternoon. The floor is yours.
And thank you for setting up these webinars, as well as for those attending to spend some time on a Friday with me to learn more about some of the treatment options, specifically high-intensity focused ultrasound as related to essential tremor and Parkinson's disease. These are a list of my disclosures. I have relations with many companies that are involved in manufacturing and producing advanced therapy options. I think it's important for providers to be involved in technology development to advocate for our patients. This is an outline of what we're going to talk about today. First, we're going to discuss what is essential tremor, as well as what is Parkinson's disease. Then we're going to jump right in to talk about focused ultrasound, or also known as high-intensity focused ultrasound. First off, though, there are a number of different causes for tremors, and it's important that your movement disorder neurologist distinguish exactly what type of tremor you have, because that really dictates the treatment options. So, for example, in the top left, we have an individual who has a Parkinson's tremor. This is predominantly a rest tremor. In comparison, we have somebody on the top right who has a functional tremor. It's used to be termed psychogenic tremor. And you can see how the tremor is variable in its amplitude, its frequency, and is easily distractible. On the bottom left is somebody with multiple sclerosis who has a cerebellar tremor, really kind of this endpoint tremor and a lot of dysmetria, meaning decreased coordination. And on the bottom right is somebody who has a dystonic tremor, tends to be an irregular, jerky-like tremor, abnormal posturing as well that is associated. This is somewhat distinguished from that of a definition of a central tremor. Now, a central tremor has a very broad definition. It can be defined as an isolated tremor involving both of the upper limbs, the arms. Typically, an individual has to have symptoms for greater than 3 years. You can sometimes see other parts of the body being afflicted by the tremor, and you should not have other neurological signs, such as decreased coordination, symptoms of Parkinson's disease, or dystonia, which means abnormal posturing of a body part. Here's an individual that has a central tremor. You can see the tremor is very regular. It's sinusoidal. It does not really change with different positions. And On the other figure that you see here with her doing the writing, you can see that this tremor doesn't change really with writing in different positions. Very sinusoidal again. And this is a common task that we often let individuals perform, the line drawing as well as the Archimedes spirals. Essential tremor is one of the most common neurological disorders, afflicting 1% of the general population and over 5% of those over the age of 65. It has a bimodal distribution, being more common in those in their second and sixth generations, 6 decades of life. The prevalence is incredibly common and is reported in those over the age of 65 to be similar to that of Alzheimer's disease. Now, we're not going to spend a lot of time about the circuitry of essential tremor, except to point out that where we tend to disrupt surgically essential tremor is within a relay center of the brain. A major relay center of the brain is called the thalamus. Pretty much everything goes into, is processed, and then out of the thalamus. And where we disrupt the circuitry of the tremor pathway is when it goes into the thalamus, specifically within a nucleus, a centered area of cells called the VIM, or ventral intermediate nucleus of the thalamus. Hence, we're disrupting the pathway as it's relayed into the thalamus before it goes out of the thalamus to other areas of the brain. I like this figure because it points out that our first line treatments for medications for tremor really involve medication called propranolol and primidone. And you can see here the clinical benefit can be around 50%. Then we start talking about other treatment options, second line, third line medications, which include topiramate, sotalol, iodolol, gabapentin, and alprazolam, as you see on the bottom here. But in the hash lines is that of a surgical treatment called deep brain stimulation, which involves placement of electrode deep into the brain, into an area of the brain called the VIM. We just talked about the VIM in the previous slide. And this is similar, by the way, to the outcomes that you can see with high intensity focused ultrasound. And the point is that you get close to 90% benefit of tremor suppression with deep brain stimulation. Consequently, when somebody is already having difficulty tolerating and or doesn't have enough tremor suppression to make a functional benefit with propranolol and primidone, I'm already thinking about deep brain stimulation or high intensity focused ultrasound as a treatment option for these individuals, because I know that my second and third line medications are really only going to get 20 or 30% benefit for the individual with their tremor. Now we're going to switch to talk about Parkinson's disease, because I often get asked, do I have Parkinson's disease when I see an individual with essential tremor? And or I will also see individuals who are misdiagnosed with essential tremor, and in actuality, they have Parkinson's disease. So let's talk a little bit about Parkinson's disease here. It was first characterized by the individual who coined the name, Dr. James Parkinson, in 1817, in an essay called Shaky Palsy. This is an individual with Parkinson's disease. Parkinson's disease, as the distinction, tends to involve a rest tremor compared with that of essential tremor, which is more of a postural or action tremor. Tends to involve more one side of the body than the other side of the body. It's typically asymmetric. You can see here, when she holds up the arm, there isn't much tremor. That's a distinction between that of essential tremor. However, as she continues to hold the limb out for a period of time, 5-10 seconds, you can see that that tremor, quote, re-emerges. It's very characteristic of Parkinson's. Also, the individual tends to have a slowness of the movement over the period of time. We call that a decrement of movement. And you can see here with walking, she tends not to swing necessarily one of the limbs. And this is also when they walk, we can see that type of rest tremor. Parkinson's disease, consequently, is characterized by 4 cardinal features a rest tremor, slowness of movement, and typically a change in gait or postural instability. And the one that I can't show you is stiffness, meaning rigidity, we say, of the limb. Parkinson's disease is also a very common neurodegenerative disease. You can see the prevalence is here, and you can see the estimated number of people afflicted by this in 2030. It's also an incredibly expensive disease, both with indirect and direct costs, as you can see within the billions. So how do we define, quote, advanced Parkinson's disease? Because when somebody's in the advanced stages is when we start thinking about these surgical treatment options. First of all, there's no clear definition. However, when an individual starts to manifest with what we call motor complications, that's when we start to think about these treatment options, the surgical options. Motor complications simply means motor fluctuations and or dyskinesias. So when an individual has motor fluctuations and or dyskinesias, that we can define as potentially having advanced Parkinson's disease. And what we mean by motor fluctuations is when the individual takes medication, they feel good. The medication reduces the tremor, reduces the slowness of movement, the stiffness, and might also maybe help with the walking, the gait. However, after a period of several hours, those symptoms return and they have to take medication again. They feel good, eventually symptoms return, and they start to do this yo-yo type of thing throughout the entire day, needing to take 4, 5, 6 dosages of medication throughout the day every 2, 3, 4 hours. Having this, I feel good, now I don't feel good. I feel good. That's what we mean by motor fluctuations. And dyskinesias mean an abnormal writhing-like movement, and individuals can remember and think about what dyskinesias are when they remember, for example, Michael J. Fox presenting at Congress, and he had a lot of abnormal writhing-like movements. This is what we call dyskinesias. We start to think about when to provide these treatment options much sooner in the course of the disease with Parkinson's disease, and as you already heard me kind of allude to, also with essential tremor. And that's because when the individual starts manifesting with motor complications, we already know they've lost a lot of personhood, they've lost difficulty in their marriage, they've lost being able to do things that they typically like to do. Consequently, that's when we start thinking about at least having that discussion about what are the treatment options surgically for Parkinson's disease. We're going to jump into now and talk about one of those surgical treatment options, being focused ultrasound. It's also termed high intensity focused ultrasound and also termed MRI guided focused ultrasound. It means all the same thing. Focused ultrasound, or you'll hear me use the term high intensity focused ultrasound, involves ultrasound waves that converge upon a common point. And we have an estimated over 900 ultrasound waves typically that converge upon this single point. As you can see here, there's 1,024 elements that are positioned around a hemisphere on this point of the brain that we're targeting. And again, that point of the brain for tremor is the VIM. Where all these points converge can create heat, and we can measure in real time that heat. The targets, again, for tremor involve the VIM, and that's shown here, okay? And again, that's the relay center. However, I'm going to introduce 2 additional targets, and these are typical targets that we use for Parkinson's disease, okay? And that's the subthalamic nucleus and the GPI. Only thing you have to remember right now, tremor, we target this area of the brain, the relay center, the VIM. And later in the talk, we're going to talk about 2 other targets, the STN and the GPI, that are targets for Parkinson's disease. And we'll cover why those are targets for Parkinson's disease. High intensity focused ultrasound is incisionless. There's no scalpel. Now, I often hear people say it's non-invasive. That's incorrect. It is very invasive. What we're doing is essentially burning part of the brain. And if you ask a neurosurgeon or a neurologist, burning somebody's brain is obviously invasive. However, it doesn't involve a scalpel, hence it's incisionless. It's done in the outpatient setting. The patient is awake during the process, and we get real-time thermal measurements, meaning I can see in real time that heating that we're inducing and ensure also that we're having good clinical benefit without inducing any adverse effects. And the results are immediate. So right on the table, we see the improvement of the tremor. Focus ultrasound is approved back in 2016 to be done on one part of the brain. In 2023, we're able to do both hemispheres. In other words, treat both sides of the body. However, we have to wait 9 months between treatments. So, for example, if their individual says, I'm right-handed, I have a lot of tremor of the right hand, I want that treated, we can treat that, but we have to wait 9 months before we can treat the right side of the brain, i.e., treat the left side of the body. It's also approved for tremor dominant Parkinson's disease. Again, we're targeting the thalamus. And then we'll talk later about Parkinson's disease in subsequent slides. Insight Tech has a great resource that allows you to know about the number of different centers throughout North America who are performing high intensity focus ultrasound and can help in informing you about where these centers are located. The success of focus ultrasound, high intensity focus ultrasound, really involves two main components. One, appropriate patient selection, and the second is surgical targeting. Now, there's some basic patient selection criteria that we can cover here. One, the individual has to have an appropriate skull, meaning the skull has to be dense. It has to be hard. We don't want a lot of air in the skull. Ultrasound waves get absorbed by air. If any, for example, when a woman is pregnant, they have the ultrasound put on. If they just put the probe right on the skin, the picture of the baby is very poor. Consequently, you have gel is placed upon the belly, and then you place the probe, and you get a much clearer picture. And the part of the reason why is because the ultrasound waves then are going through liquid gel. They're not going through air. Similar concept here. The ultrasound waves, we don't want them to get absorbed in the air in the skull. We want it to go right through the skull to go to our target. Hence, we want a really hard skull, dense skull. If the individual has gait impairment, that's something that I always spend quite a bit of time assessing and discussing with my patients. And there's some other exclusion criteria. If the person can't remain on an MRI machine for an estimated hour and a half to 2 hours, that's a concern. They obviously have to be able to obtain an MRI because this is being done within an MRI. They have to be able to tolerate lying on the table, as I mentioned, for an hour and a half to 2 hours. And if they've had previous brain surgery, this can also be a concern. And the reason is because we typically will mark off, in other words, not allow those elements that are delivering the ultrasound waves to go through those areas of the brain that previously have had the brain surgery. That can reduce the efficiency, the number of elements I have to deliver the ultrasound waves to our target. There's also some basics with regards to the age requirements. I think it's helpful to actually just show you a workflow of an individual of ours who's gone through this process. Um, so this is a Mr. B. Mr. B, by the way, is giving consent for us to show his story to everyone here. He's a 71-year-old right-handed man, and he has a postural and action tremor. Okay, that began when he was in his 30s. Remember that bimodal distribution, younger age of onset and an older age of onset. And you already know, okay, it was a action and postural tremor, not a rest tremor. He's already been put on and tried our first line medications, propranolol and primidone. Okay, and even a second line medication called topiramate. His major goals are to improve his ability to use utensils, to drink. He likes to woodwork, and he wants to be able to tie the tippet onto the fly. In other words, be able place the hook on top upon the fly. Um, so these are realistic goals. And we always talk about what are the goals for the patient. And I don't go into the what are your goals for our clinical assessment, but what in your daily life would you like to see improved upon with this surgical treatment? And I need to make sure that those goals align with what the surgical procedure could provide. If the goals, for example, of the patient are to be able to walk again, but the surgical treatment isn't going to be able to improve that, then even if we do the best surgery, it will fail the individual with regards to those goals. The patient came in to discuss what are my advanced therapy options. He just wanted to know what else can you do for me. He was reluctant to surgery, and that's something that we always talk about with our patients as well. You can see here his Archimedes spirals and the line drawing that I've already shown, and this is him trying to write his hand. And this is what he looks like. So you see a very regular sinusoidal postural tremor. It doesn't really change when he changes positions. There's really no posture associated with this. This is him trying to do the finger in the nose. You can see the tremor is throughout this whole range of motion here. And again, him trying to do the spirals. And soon you'll also see him doing uh, other handwriting here. Here he's trying to write, this is a sample of my best handwriting, or today is a sunny day. And that's his signature. So step one, we determine that yes, his goals are realistic and that he does have the diagnosis of essential tremor, and that we think that surgical treatment options might be of the benefit for him. The next phase that we do is upon getting a CT scan and ensuring that he is got an appropriate skull, as we spent some time discussing, is we start looking at the planning. This is now into that part two that you saw about the successes of surgical planning. I just want to point out there's a number of different ways to do surgical planning. We, along with a number of other centers, use a lot of different modalities that we combine to ensure that we're targeting exactly where we want to be. One method is using indirect targets, and that simply means that you go so many millimeters from a certain point. Let's say here are the posterior commissure, which is a point right here. You go so many millimeters in front of that point, or such a percentage, and so many millimeters above, and that's where you do your lesion. Another method is you apply an atlas, which is a mathematical modeling of what the computer system predicts to be. For example, in pink here, the VIM, which is the area of the brain that you would want to target. A third option is also using tractography. And this is where you can map out and say what is the possible tremor track that you want to target, that being shown here in gold, as well as, importantly, tracks that you would want to avoid. So in pink here is the cortical spinal tract. This is the motor track. You want to avoid this track. If you burn this area of the brain here, you can get weakness. In blue here is the sensory pathways. So if you burn back here, what could happen is you can get loss of sensation. Things feel kind of numb. You're getting an idea already of, so if you go a little bit too far over, a little bit too far back, you're going to run into some challenges with adverse effects, that being either weakness and or sensory change respectively. So this is why we have to take a lot of time in ensuring that we're targeting accurately. A fourth option that we are using, as well as other centers, is an F-gator sequence. which allows us to see this hypodensity, meaning this dark area in the brain. And we think this corresponds with that tremor pathway. And that tremor pathway you might see in some slides. I haven't said exactly what it is, but it's called the dentorubral-thalamic tract, or DRTT. It also allows us to see this area of the brain here, what we want to avoid, and that being the internal capsule where that cortical spinal tract is located. And as I've already alluded to, we combine all of these techniques to ensure that we're going to be right at the spot that we think is the ideal target. We, along with some other centers, also burn in that image directly so that we know essentially that X marks the spot. The other nice thing, by the way, is that during the procedure itself, we can see the heating and map that right upon our target to ensure that we're right exactly where we want to be. In other words, if I saw this blue way over here, then I know that I'm completely off the target and I need to move the targeting back upon our plan. Another point that's also kind of helpful to see is that we can also, after the procedure, for example, see that area of the brain that we've lesioned, that we've created that burn, that hole, and where that corresponds with our plan, our targeting. And in this example, you can see here is this blackness right here. And you can see this is right completely over the target at hand as to what we wanted to perform. So you heard a little bit about all that work that we do with the planning. The day of the procedure, the individual comes on in. We will repeat some of the neurologic exam. We get an IV. We give the person anti-nausea medication, as well as analgesics, that being Tylenol, for example. And we do that because the procedure can be painful. The individual can experience heating around the skull when we perform the procedure itself. And the procedure meaning when we're delivering the ultrasound waves. And the ultrasound wave delivery ranges, but tends to be anywhere in our center 12 up to 30 seconds in duration. So there can be a sensation of heat, which is painful around the skull only during that time period. So seconds in duration, but we try to mitigate that. In addition, the individual could get nauseous during the procedure, which is why we give the anti-nausea medication. Unfortunately, we have to shave completely the head, and that's because we want to make sure that those ultrasound waves are not being deterred by anything in the way, in other words, hair. And we don't want to heat the hair at all during this procedure. A head frame is placed, and the reason for that is that locks the head into the head frame, and that head frame is then locked to the table. And that's because we do not want to have a moving target when we're performing the procedure. A silicone membrane is placed, and you'll see why that is. And then the person is positioned onto the scanner. Importantly, the individual having this procedure performed has a button, and that button will stop the delivery of the ultrasound waves immediately if the person presses it. So the person is always in control. So, for example, if you're experiencing a tremendous amount of pain and you can't tolerate it anymore, you can press the button and it stops. If you get nauseous at all, you press the button and we come on in and evaluate. In one of the systems, what we end up doing is we have a lot of planning. We merge pictures that we have obtained. We take all the work that we did before, we pull this in, we get a new MRI, and we make sure we mark off areas of the brain that we want to avoid, as well as ensure that we're right on our target. This takes anywhere from about 20 minutes or so to actually perform. And while this is ongoing, the individual unfortunately has to just wait upon the table. Again, we can evaluate in real time what the heating is doing. And if we're concerned at all that while we gradually increase the temperature, we see that that heating is going to areas of the brain that we would want to avoid, we can adjust the heating or adjust the targeting to ensure, again, that we're right on target. And that is being exemplified here in this example, where we can see here area of the brain, let's say that we targeted and we burned, and now we said, well, that's too low, and instead we want to burn up here, you can see that we can adjust all this. And this is an example that after we perform, for example, a sonication, we can test in real time to ensure that we're seeing a clinical benefit, as well as importantly to assess that we're not causing any adverse effects. Adverse effects, again, can include weakness, sensory change, and decreased coordination. And I'll explain as well what we're looking for and how we do that during the procedure in the subsequent slides. The individual is positioned here upon the table. Again, this is the head frame that is anchored to the table. This is that rubber diaphragm. And that rubber diaphragm is connected to the transducer. You can think of the transducer as a hair salon hair dryer. And that hair salon hair dryer, the transducer, is what has the 1024 elements, which is what delivers the ultrasound waves to the target. Between this diaphragm and the transducer is cold circulating water. So the individual's head is being chilled, cooled the entire time. That's being done for mainly two main reasons. One, again, ultrasound waves don't do well going through air. It goes well through liquid. So that's why we have circulating water. In addition, it's cool because we want to make sure the skull and the skin are as cool as possible so that we don't cause excessive heating at those areas, but instead we heat our target. Now, when we perform this procedure, we gradually increase the amount of energy that we're delivering until we get to the point that we can know that we're at a temperature that is at a high enough temperature that would create a burn. We typically first start doing two to three alignments. That means that only for 12 seconds, we're delivering the ultrasound waves, and we're doing so at a very low temperature just to create a red dot. And we do it 2 to 3 times because we want to make sure that we're within our plan, both in the front and back, left to right, and up and down. In other words, 3D space. The individual doesn't feel anything typically during that portion of the procedure. Again, we're creating a red dot and comparing that with our plan to make sure that we're on target. The next part is we further increase the temperature, and this is when we get to what we call verify. The individual might feel something here, okay? Again, we're getting the temperatures that don't create any permanent damage. A temporary disruption, however, is occurring. And what that does is that makes us see, have we noticed a clinical benefit in the tremor? And do we see any adverse effects? For example, if I find that at the verify portion, again, low temperature doesn't create any permanent damage, that we can see that the person goes, yeah, I have a little bit of numbness right around my mouth right now. Then I know that we're too far back and we need to move forward from where we currently are performing this. In a matter of a few minutes, probably that person will say, oh yeah, now it feels just fine, okay? But I know that that's not where we want to be, and we'll make an adjustment. After we've done the verify, then what we do is we actually do a treatment. And again, the treatment ranges anywhere from 12 to 30 seconds in duration. And this is when the individual might feel something, and that depends upon the efficiency of the skull. So let's look at Mr. B's performance. You can see again, before the operation, what do you look like? After the fourth sonication, so this probably is after the verify portion. And we can see that, yes, we're getting a notable clinical benefit. In addition, I know that we didn't cause any adverse effects. He had a total of 8 sonications. Again, he's performing this upside down, this writing, and you can see here a significant benefit. And this is what we show with in him. You can see Here is the target here. It looks like a bullseye, and the blackness is the tissue that we have destroyed. So we're looking for two things after the procedure. We want to make sure that we've created a hole, we've created something that looks like it's going to be permanent, as well as we want to make sure that this is right over our target. And this is what he looks like. We always see our patients the next day to review everything that was done, as well as to go over any questions and evaluate if there's any concerns. Again, the hand that we treated is the right hand. The left hand is untreated. And you can see here, there's no tremor at this point in time. And this is just the snapshot of what it looked like before and what is after. Okay. So he had a remarkable benefit. This is typically what we can see with this procedure. So about a 70% improvement of that postural tremor. Their activities they like to perform, writing and pouring, is also improved by 40%. There's an improvement of disability, and most importantly, there's at least a 30% improvement of quality of life. And I'd like to point out this data that we know of thus far is at least out to 5 years. So at 5 years after the procedure, we can see this kind of sustained benefit. Now, in another 5 years, we'll have data out to 10 years, and we can say, what is the benefit out to 10 years? But thus far, as we know from the time when this procedure was approved, we got that at least out to 5 years with sustained benefit. The adverse effects you've already heard me kind of allude to throughout this presentation. It depends upon ensuring that you're on target. And if you're off target, you can get these adverse effects that can include changes in sensation, changes of coordination. You can get weakness as well. And I will point out, doing both sides of the brain, you can get, in particular, a change in sense of taste, as well as an impairment of walking. Obviously, if we do both sides of the brain, again, separated by 9 months, you can see further improvement of their total tremor, because as you saw in Mr. B, he still had a tremor in the left hand. I'll point out that he's come back and had the second side also performed and done very well. We do see a sustained benefit as well with the bilateral procedures. Again, it's at least in this study, for example, out to 1 year. I've already pointed out that there are some concerns that we do talk about our patients, and that with wanting both sides of the brain, and that can include potentially a worsening of their sense of taste, as well as an impairment of their balance with doing both sides of the brain. Consequently, for doing the second side of the brain, we, along with a number of other centers, are a little bit more conservative. So we might not create as large of a burn, as large of a hole compared with that first side, knowing that these adverse effects are a little bit greater, specifically the changes in sense of taste and the impairment of walking with doing the second side. Now, if you're savvy and read the literature, I'll point out there has been a significant change in the original 5 years ago with how we perform this procedure compared with currently. At the present time, we don't get to those incredibly high temperatures. We tend to get to temperatures of 55 or greater, and we know that's enough of a temperature to actually create the burn. Previously, we're up into the 60 range. The number of sonications, on average, we're somewhere around 6 to 8 total sonications, and sonications mean when we're delivering the ultrasound waves. In the previous times, we've been up to 12, 16 sonications. And you saw a lot of the work that we do here, along with a number of other centers, with our targeting. I'll just point out that in Parkinson's disease, for the tremor, targeting the VI is also an option, with also similar benefit that we see for tremor. And these benefits, at least that we can see in some patients, are even out to 3 years. However, in Parkinson's disease, we're going to switch now a little bit, guys. We're going to be talking about Parkinson's disease. For Parkinson's disease with a tremor, there are a number of individuals, however, unlike that really an essential tremor, who do have suboptimal responses. They just don't have as good of a response for some reason. In addition, if you remember Parkinson's disease, rest tremor, okay, fine, that's what we're talking about. But they also have slowness of their movement, stiffness as well. And those tend to be more of a bother for the individual compared with that of the rest tremor. Consequently, the two other targets that we talked about earlier are the subthalamic nucleus and the GPI. Targeting these areas, at least for example, with a procedure called deep brain stimulation, does improve slowness of movement, does improve stiffness, as well as is very effective for the rest tremor. Consequently, we looked at targeting these areas with high intensity focus ultrasound. For targeting the GPI, unfortunately, although it was shown to be fairly safe with low adverse effects profile, we find that a high percentage of individuals, up to 30% of individuals, really had no response. They had no benefit. And I think that the procedure or surgery was done correctly. It's just that these individuals had no benefit. Consequently, informing my patients that you can elect to proceed with a neurosurgical treatment that might give you 30% benefit. And even the benefit that they get is even kind of suboptimal, really is concerning. And maybe there's better targets to look at. We also have, as a community, looked at subthalamotomy as a treatment option. And it's kind of the exact opposite to that of GPI. What we can see here in targeting that STN, the subthalamic nucleus, is a notable benefit with regards to their rigidity, their stiffness, and their tremor, compared with that, for example, of a sham, meaning these individuals thought that they had the procedure, but they really didn't. But again, unlike GPI, that was looked fairly safe, low adverse effect profile, in targeting the STN by doing high intensity focused ultrasound, the adverse effects are actually much higher. We can see notable impairment of gait. And again, this is a patient population that already has an impairment of gait. Speech changes, individuals can have some weakness, as well as runaway kind of dyskinesias, almost like. They can have an increased amount of dyskinesias that are also a concern. So for this reason, with regards to, yes, the GPI looks safe, but really not the greatest clinical benefit. Complete opposite kind of story with STN. Good clinical benefit, but we wish that we had a better adverse effect profile. Individuals have been looking at other surgical targets for Parkinson's disease with regards to high intensity focused ultrasound. And one of those targets is that called the palatothalamic tract. Similar to what you saw where we target the VIM for eccentric tremor being the major relay center, where everything seemed to kind of come into the VIM before it went out to the rest of the cerebral cortex, we're doing something very similar here. The major pathway of the basal ganglia, when it comes into the thalamus, that pathway is called the PTT or palatothalamic tract. And it's at that point when it's coming right into the thalamus, which is where we're trying to target and see if we can note clinical benefit as well as ensuring that we don't cause adverse effects. This is a summary slide of the data that at least the present time has been published. We know that there's been a total of 127 individuals, hemispheres that have been performed and 57 being both sides. We can see that there's notable improvement both about 40 to 50% and up to 35% when we look at individuals when they're not taking medication compared with on. There's also an improvement of dyskinesias, meaning abnormal wiggling movements, and we're waiting really to see what are the adverse effects potentially with doing this procedure. One of them that we must make sure and monitor is that of any changes with regards to sleepiness or confusion. And the reason why is because we're close to another tract that we would want to avoid, the mammal-thalamic tract. So there's much more that we're learning and more to come with regards to targeting the PTT. I will point out that this area of the brain has been approved back in July of last year as a surgical target for us to consider in our patients with Parkinson's disease, with potentially much favorable outcomes compared with that example of GPI, with potentially less adverse effects to that of targeting the subthalamic nucleus, again, as specific to high intensity focused ultrasound. So in the last couple slides, just a few points about us. One, we're one of the most comprehensive advanced therapies movement disorders team within at least our region. We can see here, much like many larger centers, there's a host of individuals that encompass our team: neurosurgery, neurology, neurophysiology, neuropsychology, neuroradiology, supportive palliative care, psychiatry, and our wonderful staff that we can't do this without them. We do have a team approach. So individuals that come into our center, we try to coordinate the number of appointments so that it's reduced the number of times the individual would have to come. They see typically the neurologist and the neurosurgeon. We try to coordinate any imaging that is also needed to be done. Upon that being completed, our nurse navigator, nurse coordinator, DVS nurse work together to ensure that we can talk about the patients on a weekly basis. So the entire team comes together virtually to evaluate the patients that have already gone through the process to determine if they're a candidate or not. And that is something that's very common that we do along with a number of other centers. We have quite a bit of experience as well with surgical targeting, both from high intensity focused ultrasound experience as well as from that of deep brain stimulation. And you already saw that we use a number of different tools to ensure that we're within our target. In addition, when we perform this procedure, it's performed by neurology and neurosurgery together, and the assessments are done by a movement disorder neurologist evaluating for clinical benefit as well as assessing for any adverse effects. Now, I know that there's typically a number of questions that are often asked, so I want to make sure that we have enough time. This is our information that you can contact and request us to be evaluate you. If there's any questions, please pose them in the chat at this present time. And I thank you all for your attention, especially on the afternoon, on evening on a Friday.
Dr. Kern, you have someone on here who is a big fan of yours.
Okay.
You have a past patient. Obviously, I'm not going to share names, but they want me to read this out loud that they were in to see you about 2 weeks ago and that you underwent essential tremor procedure and that his was a pretty complicated procedure, took a little longer than normal, but that the final results exceeded expectations and he can basically say that his tremor is completely gone. And he also wanted to make sure that we said that he did not get asked to express his opinion and that his actual sense of taste seems to be slightly better. So, yeah. So I thought I would just read those out loud for you to kick us off. And then again, if anybody wants to have specific questions, like Dr. Kern said, feel free to put those in and we'll go ahead and answer them right now. So this person is scheduled for an appointment evaluation. They said during one of the previous presentations, they understood a referral was not required. But when they contacted your office, they were told they did need a referral. Can you just talk through that a little bit so that everyone understands if they call in um, after he re obtained is obtaining the referral and calling again, he was informed that your office is not currently accepting new patients. So, for the people that are on now, can you tell them, do they have to have a referral from a physician to come in and what the time frame looks like to get in to see you currently um, for this procedure?
So a referral is asked of us to be able to get them in the queue so that we can make sure that we can review everything that has actually already been performed by the individual. So it doesn't have to be put in by, obviously, a neurologist can be put in by anyone else at this present time. At the same time, I will point out that that's not necessary because we do use, for example, Insight Tech's option which allows the individual to essentially have a discussion with us, and then we then can have the individual come directly in to see us. Our timeline, by the way, is yes, of course, we're seeing new patients. We actually just are in the process of hiring a nurse practitioner with the goal from the time of a referral or the time of the individual being asked to be seen within less than 2 weeks. So within less than 2 weeks from the time of referral, the individual should be able to get into see us into our system, see somebody of our team. I think this is essential because we know that we're a large system, much like many other locations are large systems. And we're trying to make it that, yes, we have a larger team, but in actuality, we've got individuals whose whole job is to manage the logistics and streamline this entire process. And it's just a matter of getting the individual in. And then once they're in, they have a contact. They got an individual they can send a message to. They got somebody that they can call directly. Hey, I'm having trouble with arranging for the MRI to be done. Okay, let me work on that so that we can set up that for the individual.
So I know this person that's asking the questions about this. I'm just curious if they haven't, if they see the email that's on the screen right now and the phone number that's on the screen right now, I would say go ahead and give them a call um, this upcoming week and see if that could help because those people are there ready to answer questions and help you through the process. So make sure that you take your phone out and take a picture of that and make sure that that's the phone number and the email that you've reached out to. Um, this person is asking about how long the actual procedure takes and can essential tremor come back?
Uh, Great questions. Question first. The procedure itself, from the time that the individual comes in, we have to have the individual come in, IV placed, head shaved, comfortable, placed on the table, right? So that all takes time. And then once the individual is on the table, from the time that the person comes off the table, typically a goal is about an hour and a half. Okay, sometimes faster, sometimes slower. Really depends upon the individual's response to the procedure at the time. And then the person comes off the table. We remove the diaphragm, remove the head frame. We do then get another MRI at that point, and that MRI takes anywhere about 9 minutes, and that's so that we can see what we've done and map that upon our plan. So if you're talking about the total amount of time, for an individual, I'd say it's about 4 hours, but that's from the time that the person typically walks into the door to the time that we make sure the patient's doing okay and subsequently leaves. We do about two a day. We're probably going to be up to about three a day very soon. And hence, an individual comes in at 7 o'clock. Typically, they're completely done with everything before 11 o'clock. Typically, by about 12 o'clock, they want to get home. And then the next patient comes in at 11 o'clock, wants to leave by typically 3 o'clock, and then the third patient around 2 o'clock and leave before about 6.
Perfect. And is it possible for essential tremor to come
Um,
back?
Thank you. Sorry.
No, you're
Thank you
fine.
for reminding me.
Of course.
So there's 2 points here. One, if we go back to this slide, it exemplifies one point. Okay. Essential tremor is very slowly progressive. okay, it doesn't change that trajectory, at least that we know. So if you look at 5 years, for example, here, okay, we can see that, yeah, compared with before, that's a significant drop, okay? But you get this idea that there's a slow progressive trend over the period of the 5 years of the slight worsening of the tremor. Now, we don't know what this looks like beyond 5 years, but that's one point. And I will say that there is estimates by a number of individuals that probably less than 5% of individuals, despite the fact that we create that burn right on the target, the individual has a remarkable benefit. And I have seen this in a couple patients that the tremor starts to come back. And it doesn't come back within weeks. It comes back over the period of months, very slowly. And it's unclear why this is because we know we've created the burn, we know we created the lesion. This is obviously not just reduction of swelling that's occurring because this is progressively getting worse over the period of many months. And I'm not sure why that is in select individuals. But we've seen that as well as a number of large centers have also seen some individuals have this return of the tremor. And again, that's very rare, but that does occur. At least in our experience, it's been 2%. But in other people will say it's anywhere from 2, maybe up to 5%.
Great answers. Um, is the treatment covered by Medicare for Parkinson's?
Um, so the biggest challenge there is insurance coverage. You're exactly right. And so for tremor, we have noted significant difficulty in getting coverage. And for PTT, it's also in the same story. So we work with the insurance companies so that you would know well ahead of time if it's covered or not. But that is a challenge at the present time. Obviously, PTT was just recently in the realm of things approved, and so it takes some time for codes, CPT codes, etc., to get updated to be able to actually provide reimbursement.
Correct. Tremor dominant Parkinson's is covered, but Parkinson's, we're still waiting for insurance to catch up since it was just approved. This person, I have cervical dystonia and essential tremor. Can this help both?
Hmm. Well, it's not approved for cervical dystonia, so I'll stay on task with that. And it is obviously notable improvement for essential tremor. But the question raises a concern, and that is, what is the correct diagnosis? Because right now you're asking for two diagnoses, essential tremor and cervical dystonia. Or does the individual have just one diagnosis, that being dystonia? And in actuality, the essential tremor is really what we would call a dystonic tremor.
Mm.
And dystonic tremor tends to be an irregular, jerky-like tremor. It can actually even look like that being of, I'll look back here, look like that being of a central tremor. And so this is the first point that I brought up actually, which is it is absolutely essential to ensure that you have the correct diagnosis. So this, for example, is an individual that came in, quote, having a central tremor. And you can see he's got cervical dystonia, meaning abnormal posturing of the head. And he had more of an irregular, jerky-like tremor. And the tremor was most prominent when he was writing. And so in actuality, this individual had dystonic tremor. And that was the unifying diagnosis. And so you want to make sure that the diagnosis is correct. Now, can this be effective? Again, this would be completely off label. In individuals that do have some features of dystonia, let's say, and they have essential tremor predominantly, we do slightly maybe adjust the targeting and we can see a potential added benefit in that realm. But again, that's something that you really want to talk with your physician about.
Great answers. If I have been diagnosed by CU Neurology, with essential tremor, will I still need a referral?
No, you don't need a referral. If it's with one of our team members in the movement disorders team, typically what occurs is they'll do either a video telehealth visit with one of the core faculty members that are involved in advanced therapies, but you also would see one of the neurosurgeons. And that can be easily expedited through our staff team.
Great. Is this supported by VA benefits?
Yeah, so we have a number of patients that are of our veterans. Obviously, our VA is right on the same campus as Anschutz, and we have even one of our core members of our ATMD group is one of the VA physicians, and those individuals come right on over. They don't need to see myself necessarily, and yes, this is covered, and we've been able to perform this on a number of our veterans as well.
Perfect. And then just one more question about insurance. Does Medicare cover essential tremor
Yes,
for this? I
yes.
want to make sure we said it out loud for everybody to hear. And then someone is just asking about recovery, about how long is the recovery for after the procedure?
Excellent question. So the recovery is somewhat dependent. You heard that wonderful one of our patients that said, 2 weeks and he's doing really well. So that would be typical, but we always cover the risks, and some of our patients can have an impairment of balance. Uh, and typically, I always tell my patients, expect that your balance immediately after the procedure is going to be impaired. And what our patients report is that they feel like they got off of a boat. They feel kind of rocky,
Mm,
okay? Or they feel like they've been at the fairgrounds on the Ferris wheel or at a roller coaster. They feel a little rocky, you know. And I think that makes a lot of sense because these ultrasound waves also go through the semicircular canals, and that fluid in the semicircular canals is spinning, and we have to wait till that spinning kind of goes away. So that typically resolves at the end of the night. Um, an impairment of balance can occur, and that can occur with the swelling because we're pretty close to those fiber tracts. And that usually resolves over the period of 2 weeks. Um, some individuals, we might notice that right at the time of the procedure, when we see the person in the recovery, they say, yep, yep, my sensation is totally normal. I see the person the next day and you say, just this morning I noticed a little bit of numbness right around my mouth, the corner of my mouth. And then I say, well, you didn't have that yesterday. I can see that that's probably secondary to the swelling. As the swelling goes down over the period of the next couple of weeks, I suspect that will completely resolve, and a number of patients will also have that. So the recovery is actually quite good for this as the general gist. Obviously, assuming that you're right on the target, you might also, by the way, feel quite a bit of fatigue that day. Individuals in the recovery room, they go, "Yeah, I feel great, I feel fantastic," and I remind them, "Look, you're running on adrenaline right now. As you go home, you get something to eat, you're going to feel wiped out," and that's very typical. Our patients will say, "Man, once I got home, I was really tired." They sleep, they wake up, they feel better the next day. Very rarely individuals will have a headache after the procedure that can be a little bit persistent. And then we might have to treat them for a short period of time with some medication as well. So recovery is quite good. Fatigue, slight impairment of balance, like you got off a boat, resolves after about 12 hours after a good night of sleep. Next day, maybe a little bit of balance impairment. We monitor, and that's why we always see our patients the following day. And if there's any other adverse effects that we need to address, we always discuss that.
perfect. So we have one more question left, Dr. Kern, and this is a really good one because we really haven't talked about this. What are the indicators, or how bad does the essential tremor need to be in order to be selected or have this treatment?
Um, Individual specific, right? So an individual, for example, that's a politician, a speaker, let's say, and doesn't want to demonstrate any form of tremor whatsoever, right? Because they're in the public limelight. That individual will say, that's enough tremor for me. The medication isn't working. I can't have that type of tremor whatsoever. Okay. That makes a functional difference for that individual. Take that same degree of tremor, and it's somebody living in the nursing care facility. They're not bothered by that degree of tremor whatsoever. Okay. So that individual might say, look, I don't want to proceed with an electric brain surgery. The tremor doesn't bother me on a functional basis. So it really is dependent upon the person. And in fact, there are scales that have been documented that it's the functional impairment of the person that we really need to take into consideration, not what the clinician perceives as a certain degree of tremor. And that functional degree of impairment assessed by that person, how that person's views their tremor, is really needs to be considered and part of the decision making, which we do and a number of other centers also do in the decision making for whether or not they're a candidate with regards to the tremor. So the individual who likes is a fly fisherman and can't tie the tippet onto the fly because because of the tremor. That's enough of, and the medications don't work. That might be enough of a tremor that we would want to treat. Because after all, the individual, we describe ourselves as to what we do, and that we use nouns to describe that. So that person identifies him or herself as a fisherman or fisherwoman. They don't say that they like to go play fishing. And then all of a sudden, we've taken away that personhood of that individual. And so we want to think about that in our decisions upon bringing that back. So the bottom line is that is a lengthy discussion that we have on an individual basis with each person uh, in assessing the pros and cons of the surgical treatment options.
What a great answer, Dr. Kern. That was really good. I haven't heard it actually expressed that way before, so thank you so much for that. And we've come to the end. There are no more questions. And so I do want to say thank you, Dr. Kern, because you also gave up your Friday evening to spend some time with these people that wanted to get information too. So appreciate you for doing that as well. And we're going to go ahead and close this out. If there's anything else that you would like to add, feel free to, do that and close us out, and we'll all enjoy a good weekend.
Well, I don't want to hold anyone up, so have a wonderful weekend and thank you all for your time. Take care.
Thank you.